At the outset, I am thankful to organizers for inviting me to speak on vaccines in diabetes, because this is much less discussed and topic among the clinics. I would like to first more discussed, or at least one session in every conference I had attended includes the vaccines in diabetes, but it is not discussed in our OPD setting most often. And after listening my 10 or 12 minutes talks, I must assure you that for the next 7 days, at least for the next 7 days, you might try to discuss the importance of vaccine in people with diabetes. And I think so, there is some error, but the first slide was pneumococcal and influenza infection leads to high mortality, and those individuals who have a long duration of diabetes, that is more than 15 years, have a mortality up to 50% once they encounter the infection. There's a huge mortality burden. We were talking since morning and tomorrow also to prevent the hard MACE endpoint with the drugs, and that to in a tune of 16%, 25%, 22%. But just vaccinating in comparison to the drugs which are discussing right now, it is much cheaper to prevent the that hardest endpoint of our life. So I will stick to the type 2 diabetes today, adult vaccination, not the pediatric vaccination. And this is a recent publication from our RSSDI members, the stalwarts in the field of diabetes, Dr. Sanjay Agrawal, Dr. Bansi Sabusar. And this is 2024 guideline recommendation, recently published, and you can visit at our RSSDI website also. The pneumococcal vaccine, influenza vaccine, hepatitis B vaccine, Tdap vaccine, Shigel's or zoster vaccine, and respiratory syncytial virus vaccine. There are 100 serotypes of streptococcus pneumoniae, and among those we have vaccine for first 13, that is PCV13 was the first pneumococcal conjugate vaccine. Then subsequently the pneumococcal polysaccharide PPSV23. Unfortunately, PSV15, that is pneumococcal conjugate 15, and pneumococcal conjugate 20, PSV20, are not available in India currently. And this is an important consideration that we need to take into account whenever we are advising our patients pneumococcal vaccine. According to the research by Grenberg et al., those patients who are naive to pneumococcal vaccination, you need to give the oldest one, that is PCV13, and that increases the pneumococcal response to subsequent administration of PPSV23 for several common vaccine serotype. This is a little bit clumsy slide to understand the serotypes, but if you can take the pictures, or even if you visit the our Indian consensus guideline on adult immunization, this is again a good paper to read out. Whosoever want to understand the vaccine in adult. So the serotypes which is covered by PCV13, subsequently many of the serotypes are also covered by PPSV23. So it is must, I would like to say, that administer the PSV13 first and subsequently PPSV23 later, because we have only 2 vaccines are available, not 15 and 20. So route of administration, intramuscular or subcutaneous, PSV 13, intramuscular injection, PSV 13.5 ml and PPSV 23.5 ml. One dose of PSV 13 followed by PPSV 23 1 year later. So in a nutshell, 0.5 ml intramuscular 13 followed by 23. That's it. Okay. Storage standard recommendation 2 degree to 8 degree centigrade. You can co-administer with herpes zoster vaccine, seasonal influenza vaccine at the same time if required, and age is more than 50 years. One dose of PCV 13 followed by PPSV 23 or 1 year later. And if needed, more than 5 years or equal to that after previous PPSV 23 dose. Before moving ahead, what is the biggest challenge we are facing while dealing with the vaccine? What is the biggest challenge? Of course, cost. The second biggest challenge? Exactly, stigma related. And the biggest challenge I would like to say that for a clinician point of view, the patient, whenever they came to our clinic, they don't have any disease, pneumococcal influenza or whatever it is that we are discussing. And as soon as we are giving the shots, the patient have even a fever, mild joint pain, mild weakness, fatigue. And in India, once any side effect occur, the patient and relative have a right to call us immediately. Okay, the patient feel I was completely okay and with their injection I am suffering this. I think so, really, I would like to frankly admit that, and you all have encountered during the COVID-19. Okay, those calls were coming that I am suffering from body ache, fever, vaccine, I don't require this vaccine, and why have you advised that? Okay, and frankly speaking, I am really afraid and I am really don't want these side effects to happen, frankly speaking, because we all are busy clinicians. So this really deters me actually, okay, to advise the patient. This is, many of you think, oh, it's a simple thing, okay, but many a times, once subsequently you are giving the vaccine, then subsequently they are coming to our clinics and they are calling, because sometimes it takes 2 or 3 days also to when that fever go away, okay, and sometimes we have to check the also, okay. So the patient's always nagging even for a milder side effect. It's although it's a good immune response that we all know that, but the patient and relative do not understand. Again, there are some issues with the slide deck. Okay, so I'm extremely sorry for that. I have already checked, but probably due to old generation software, this is occurring. And where I am, influenza vaccine, yeah. So why influenza vaccine actually? So why influenza vaccine actually? Okay, the influenza vaccine, okay, we encounter the influenza virus every year. And every year the strain is changing. Okay, and every year we need to take influenza vaccine. But the inflammatory response we get from the influenza actually, that is so detrimental that it increases risk for cardiovascular death actually, okay. That we are talking about the prevention of inflammation. The flu shot actually really preset the low grade inflammation that doesn't translate into the cardiovascular event actually, okay. The patient, due to the viral infection, particularly influenza virus infection, die due to cardiovascular disorder. The inflammatory burden, the cascade of inflammation is happening with the influenza virus, and that's what we had encountered in the COVID-19 also. Okay, those who have a higher inflammatory response actually, supraphysical response, will have a more morbid complication and have a higher morbidity than those who do not. And of course, what are the high-risk individuals for influenza influenza infections? Of course, the pre-existing diabetes, aging population, those who have a comorbid condition like chronic kidney disease, patient who have already established cardiovascular disease, you can say post-CBG, post-PTCA, low ejection fractions, and all sort of things. So influenza infection, inactivated influenza vaccine, IIV induces a recommended trivalent and quadrivalent influenza vaccine. Intramuscularly is the route, and the live. So one is inactivated influenza vaccine and one is a live attenuated influenza vaccine. And the important thing to note here is that it can be given intranasally also, so you're not required to give intramuscularly. So a little bit luxury for the patient side. You can co-administer with 2 or more following the virus vaccine are to be given. MMR, VAR or yellow fever, they should be given on the same day if it required. So yearly dose, and adults who have not received the vaccine should continue to receive it through the entire influenza season, especially during the times the virus is active in the neighborhood, before the monsoon is in the southern India and before the winter in the northern India. Hep B, we all know about the Hep B, but still for the session highlight, you need to store between 2 degree to 8 degrees centigrade and recombinant DNA or plasma derived inactivated subunit of vaccine. Deep intramuscular injection in a deltoid region. This is very specific. It should be given very deep intramuscular, and to avoid the buttocks. Dose 1 ml, 3 doses we all know, 0, 1 and 6 months, and subsequently the booster dose recommendation after 5 years. Tdap vaccination, intramuscular injection 0.5 ml, 1 dose every 10 years. And those who were unvaccinated, because why it is 110 year? Because we all have been given this Tdap vaccine in our childhood. So those who were not given, so you need to take the history beforehand giving Tdap vaccination. So unvaccinated, 1 dose is Tdap, then 1 dose is Tdap 4 weeks later, and then the 3rd dose is of Tdap 6 to 12 months. So I was surprised, and I checked my my son's pediatric immunization schedule, and I looked for, okay, there are 3 doses there actually, okay. So that is why 1 dose is every 10 years, okay. And if the patient had not taken, then you need to subsequently follows that again. Okay, it is there, but it's not here. The point is that, yeah, it is not here. That's fine anyway. So you can look from there. So, and I can use the technology here. And this is the biggest advantage to share my slides on a WhatsApp actually. Okay, so I can immediately see the WhatsApp slide. So varicella zoster virus is a causative agent for chickenpox and herpes zoster. The following the primary infection with chickenpox, shigella develop at a later stage due to reactivation of latent varicella zoster virus. So most of us have been encountered with the chickenpox actually in our childhood. Fortunately, we at that point of the time vaccination was there. So it's a latent activation. So where the latent activation happen actually, so whenever your immunity is compromised, and we all know that diabetes patient population have a compromised immune system, and we all know that how it is cumbersome for the patient and for us to deal with the post-herpetic neuralgia pain. Okay, it's very nagging pain, and in spite of giving all sort of analgesics, drugs, it is very difficult to control many a times. And this is apart from the post-herpetic neuralgia issue, this is a study with a good heterogeneity, 100% heterogeneity, and this is a excellent power in terms of this study, that association of herpes zoster incidence among diabetes versus non-diabetic individual. And on this forest plot, you can clearly notice that those individuals who have been given herpes zoster virus vaccination have a less chances of cardiovascular disorder. Again, for a CKD also, they have a less chances for those who have been given single vaccine. Recommended zoster vaccine, route of administration, deltoid or enterolateral thigh area subcutaneous injections, age more than 50 years or above, 2 doses, 0.5 ml, 2 to 6 months apart, and do not expose to direct sunlight or heat, and should be stored between 2 degree to 8 degree centigrade. Respiratory syncytial virus is not available currently in India, and I am running short of the time also. But I will have a very brief take-home messages for all of you, that we must encourage adult vaccination in our day-to-day practice, and we require a lot of collaboration in between hospitals. We need to do a lot of patient education program, camps and awareness. Also, a much bigger change is required in society for acceptance of adult vaccination. Although many prominent healthcare societies in India have initiated adult vaccination program, the absence of standardized schedule as it is in pediatric populations, it is of need, and it is a notable gap also. Vaccine hesitancy among individuals, adult individuals, which can be defined in delay in accepting or refusing vaccines despite the availability of vaccine services, and can be the reason to blame for overall drop in vaccination coverage. The goal of vaccine is to build the herd immunity that it provides. Vaccine promotion is important in community, as I highlighted, and community nurses should promote and ensure each individual is vaccinated in the community. And of course, a team approach is required among all of us actually for better acceptance of adult immunization program. Thank you.